which is on rectal cancer. I now invite our session director, Dr. Vedant Kabra, surgical oncologist from New Delhi. Our two chairpersons are Dr. J.D. Patel, surgical oncologist from Ahmedabad. And our second chairperson is Dr. Alok Ghosh Dastidar, radiation oncologist from Kolkata. I also invite our moderator, Dr. M. Vamshi Krishna, medical oncologist from Hyderabad. So with your permission, I'll also invite your panelists. Dr. Padmaj Kulkarni, medical oncologist from Pune. Dr. Sivadeep Chakraborty, surgical oncologist from Kolkata. Dr. Saumin Das, surgical oncologist, Kolkata. We have Dr. Avinash Saklani, who's joined us virtually, colorectal and robotic surgeon, Mumbai. Dr. Durva Kurkure, radiation oncologist, Mumbai. And Dr. Rahul Krishnatri, radiation oncologist, Mumbai.
I would like to invite Dr. Vedant Kabra also. So he is the session director and he has been instrumental in preparing all these slides. So good afternoon everyone. For those who are willing for a postprandial session on rectal cancers. And sir? No willing. We have to be here. Very good. Excellent. So just to confirm, we have Dr. Dastidar here. Dr. Krishnati, Rahul Krishnati has joined us, or he's... So he's here somewhere? He's here somewhere. Very good. And Dr. Divya? Avinash sir is not joining us. So excellent. So we have Dr. Saumin Das, Dr. Subhadeep. Dr. Subhadeep is not there? Okay. So Dr. Saumin, Dr. Padmaj. And all right. So I think our chairpersons will be part of our session, I guess. Dr. Alok Ghosh? Sir, Dr. Alok Ghosh is there and Dr. Patel. So we have the panelist as chairperson and the moderator. So these will be the guys who will be answering all our questions. Can I have the slides, please? Great. 59 minutes. They cannot see you in the camera. Both of you, they cannot see you in the camera. Right. So what we will do is, if you have to summarize how rectal cancer has changed in the past several decades, mainly with the help of a MDT. That's been the reason why things are changing. Over in the early 1970s and 80s, suboptimal staging, suboptimal treatment, non-TME, no treatment of the nodes done, recurrence rates were high, 15 to 40%, and 5-year overall survival is only around 30 to 69% in the various groups. Then we had emergence of TME, better imaging, endorectal ultrasound, pelvic radiotherapy. So then the rates of pelvic recurrence reduced. So you had only 4 to 15% recurrence. Distal recurrences became important. So that brings us to this era where we have started looking at uses of neoadjuvant and systemic therapy to improve the distant recurrence controls. Right? So that's where the whole journey of rectal has been in the last few years. So we'll start with a case. So the case study, it's a 56-year-old lady, no major comorbids, no family history, bleeding PR, presented with no other history of weight loss or any other complaints. Performance status 1, PR, mass was just palpable, sphincter function good. Okay, so this was done by a surgeon, not by me. So anyone who is doubting a medical oncologist's finger, it was done by the surgeons. Right, this is the colonoscopy report. So as you can see, a mass which was present from 5 centimeter above the verge, biopsy showing a adenocarcinoma well differentiated. So let me start off with the panel, the ones who are here. So Dr. Saumin, since there's a surgical case, first comes to the surgeon. What would you do next? What imaging would you like to do?
Yeah, so this is a rectal carcinoma. The next step is to do the staging. I would like to do an MRI pelvis with a CT thorax and upper abdomen.
Okay.
Along with that, a CEA and other routine investigations.
Okay, so MRI and CT scan abdomen and chest. That's your staging workup. Excellent. Dr. Rahul? Agreed. Okay. Dr. Divya, would you agree with that? Imaging for a patient who has come with a CA rectum, 5 centimeter above the verge, adenocarcinoma, well differentiated, no comorbids, 56-year-old, performance status 1.
Yes.
Again in MRI. Excellent. So I think everyone has said. So just as a matter of curiosity, is it an MRI contrast with a coil or is it just a normal MRI contrast? What's routinely being done in your centers? Just asking for a reason. Dr. Vedant, you want to make a comment on that? Yeah.
Yeah, it used to be endorectal coil earlier, but then it's not practical always because of the disease being there. So it's actually not needed, but you have to have a rectal protocol whereby certain sequences have to be taken, and it has to be a synoptic reporting on EMVI, on MRF.
That's the next question I'll be coming to. Great. So, Dr. Padmaj, medical oncologist, we like doing only PET CT scans. So, would you advise a PET CT scan also in such a case along with the MRI contrast and CT abdomen?
I think if CT scan abdomen pelvis and MRI does not show any locally advanced disease, the plane is fine, there are no nodes, the PET CT scan is not warranted.
Okay. If it is a locally advanced, supposing you have nodes present, and then would you still want a PET CT scan, or is a CT abdomen just good enough?
See, the superiority of PET CT scan as a routine investigation over CT scan, whatever is been done, CT abdomen, pelvis and MRI is not proven. So, you can choose either depending on availability.
I think that's kind of standard. Dr. Divya, endorectal ultrasound, we talk a lot about it. Do you routinely advise it, or is it only for very early lesions?
Routinely for early cases.
For all lesions you are doing endorectal ultrasound?
No, only when we
only
want to
early
confirm
lesions.
whether it's only
Very good.
early.
Yes, Dr. Somen, you are.
Yeah, for us, endorectal ultrasound is for those where MRI is contraindicated, or it's a problem solving where there is a confusion in the T stage in MRI.
Very good. So, by and large, endorectal ultrasound is not needed everywhere. So, either all of the above.
Hi.
Sir.
So I don't see a CT chest if we are not doing a PET CT.
I have not written it, sir. It's my mistake. It is to be done. The panelists, to their credit, have all said CT chest. I have forgotten to write it. Right. Very good. So, this is an MRI contrast. So, Dr. Vedant, you being the moderator, will get the last shot at this. First, the panel will get to answer. Dr. Somen, you have ordered an MRI contrast. What exactly are you looking for in that MRI?
So,
what all are you looking for, rather?
So, but I would like to see the T stage of the disease. MRI clearly states whether it is in upper rectum, mid rectum or in lower rectum, whether the sphincters are involved or not, what is the exact T stage, as well as what are the mesorectal status of the mesorectal nodes, what about the lateral nodes. So, these are the information which I would like to see from an MRI pelvis.
Okay. Dr. Rahul, you get this reporting. Dr. Vedant has said you need a synoptic reporting with everything involved. Do you normally get that reporting everywhere, or?
At least in our center that we are lucky to get it. But I think just EMVI as an additional information that will be very relevant.
EMVI, MRF. Dr. Divya, anything else that you would want to go for?
More or less, most of the MRI reports are incorporating these high-risk features, whether whether they are present or not. And if there's any confusion, then of course MDT is the approach that we should.
Yeah, MDT approach I will come to. For some reason, the presentation seems to have gone down. Don't know what that has happened. Fine. So again, the reason why I'm bringing out this is the same thing that Dr. Rahul is saying. In some institutes, yes, we do get such a reporting, but it is not always available and always feasible. But this is something that has to be reported for a rectal. Otherwise, you really can't manage with the patient. So again, I think typically what we would do is ask them to get the CD, give it to our own institute and ask them to review. I think that's the way forward. So the important question really comes on the nodes. How do you decide on the significance of the nodes? So Dr. Somen, at this part?
So for mesorectal nodes, there is a clear-cut criteria of 9 millimeter. So if you have a more than 9 millimeter node in mesorectum, so that is taken to be as a positive. Not only the size criteria, if you have three features, right, round shaped node, a node with an indistinct margin and a heterogeneous or mucinous nodes. If you have two criterias, then a 5 millimeter to 9 millimeter size is also okay. Even if you have all three criterias with a less than 5 millimeter node in the mesorectum, it is taken as positive. For the lateral nodes, the criteria is more than 7 millimeter.
I think textbook answer, everything you have covered, whatever needs to cover. Dr. Divya, anything? Yes? You are smiling. That's okay. I think he has covered anything more than this. I can't think of much. These are the exact, yeah.
Yeah. So I think it is better to consider the T also. You know, T would forecast the number of the nodes you are expecting. So depth, as madam said, that is most important, involvement of mesorectum and circumference. What is the amount of
CRM,
circumference?
yes.
So
CRM,
that can
EMBI.
predict that what can be seen on MRI as a node.
Absolutely. So these are the characteristics which, again, Dr. Somen very nicely said it. Dr. Padmaj, in medical oncologist, by this time we are sitting quietly normally and waiting for the radiologist. I think that's what most of the medical oncologists would do. But yeah.
I'm looking for the opportunity to do MSI now.
MSI. I have not forgotten MSI. I have not forgotten MSI. Right. So the other interesting thing, again, this was something that I was discussing with one of the experts from Poland who had come to tell, and he was kind of also telling something interesting, that look at the node and the size of the site of the tumor. If it's a left-sided tumor with right-sided nodes, you probably will not think it is that important. If there's a borderline suspicion, if it's the same side, it is definitely more important. So yes, Dr. Rahul.
So nodes, like, you know, the whole world is very confused now. With the recent data from Gina Brown, in which, you know, Lancet Oncologist is a pan-UK study that they have published recently. They have said that node doesn't matter. They come and go.
Okay.
These are the exact words of the author.
Okay.
You know, so this is not something that I am saying based on my interpretation of that.
So what? How would you interpret it?
So yeah, no. So we still are stuck to what is the real
Real
evidence, but you know, and then lateral pelvic nodes.
Yes, Dr.
Nobody knows whether we should boost it or they should take it out based on response. So node is a very difficult situation.
Okay, so you are talking of nodes in terms of the treatment for it and whether you should give the boost for it or not. So
what
not in terms of
and how much
diagnosis.
cognizance is relevant.
Fair enough. Dr. Vedan, anything you?
Yeah, what I want to say is typically we have been tuned to see 1 centimeter and beyond as abnormal. But rectum, this is a problem. And we have to insist and we have to make sure that our pathologists also dissect very well and take out all those nodes.
There are no pathologists there, I guess we can leave that.
I think here is a role of transrectal sonography. You know, the guys would be telling us whether it is metastatic or not.
So I'm not
By
sure
just
how
simple
good a
sonography.
transrectal will be for picking up lateral nodes and other nodes, probably just for, they're only for the perirectal nodes. Perfect. Perfect. I think that's again the point you just need to be concerned. Any other imaging, again role of CT, over and beyond, I think everyone has done been talking about CT chest and CT abdomen just to look for distant metastasis, not so much as in a local disease. That's what I have understood from the panel. Excellent. So for distant metastasis, other than that, I think only PET CT or CT is good enough. We will probably not use any difference in the staging. So this is one of the guidelines which tells us how you need to look at the images. Again, something that all has said. For me, it is very important that at least at the baseline, a digital rectal examination is very, very crucial. Because at the end of all the treatment, the first question people ask is how much was it? Was it involving the sphincters at baseline? That has to be documented very, very crucially. I think that is something which all the panelists are shaking. Yes.
I mean, I am a little old guy, but examination at anesthesia would tell a lot of good things, you know.
Absolutely, agreed. Especially in the time when there was no MRI, I think that finger was more valuable than any of these scopes and scans. So that is something that has to be documented, more importantly. Because, you know, patients come with papers and that paper will be missing and all will be searching for is baseline, what happened to the sphincter.
There are a lot of students here. I would request them to document each and everything. Even if you feel that this is stupid, mention it, because of us, something has been done in the form of some treatment and in the form of NSCT or anti-radiotherapy, then it becomes very difficult. What was the picture and now what is the status, you know? Because you are going to have a clinical response rating. And then subsequently you might have imaging rating also, that what is the response. So the first foundation has to be very solid.
And as usual, documentation has to be there, which again, I don't know how many of us are doing it very religiously. So then you look for the morphological classification. T stage can be for early with a ERAS or a MR, and of course MRI and CT, what we have been discussing so far. So I think that is something which all of the panel agrees on. So we'll move ahead after that. So in this patient, this is the MRI images. I don't want anyone to waste time reading it. I'll just go through the report. So again, like Dr. Rahul was saying, you're lucky enough to have a good radiology department. It makes a big difference. So we are lucky enough to have that, and the full reporting has been done. So you can go through the report. It shows it's a circumferential mixed T2 hyperintense intermediate signal density, measures 7 centimeter in length. Then the lower extent of tumor is 3.5 centimeter from the anorectal junction. Lower extent is that much, upper extent is above level of anterior peritoneal, but this is a rectal tumor by and large. CRM is involved anteriorly by the tumor, another location by the mesorectal lymph node. The EMVI is negative, no involvement of the muscles, and there is no infiltration of any of the regional structures. Multiple morphologically significant lymph nodes, largest measuring up to 8 mm, highest node is at S1. So this is where the 7 to 9 is what they were commenting on. So even if it is more than 7 but otherwise significant, you take them to be significant. Extra mesorectal lymph nodes, only one, which is more 5 millimeter short axis. So this kind of a report will tell you. We did do a PET CT for this patient at the baseline. more as a part of staging workup and for the radiation planning workup. So this was the report. Again, the report says that there is a enhancing symmetrical circumferential thickening upper and middle third with significant luminal narrowing, metabolically active, enhancing multiple perirectal and presacral lymph nodes. So final stage is clinical C T3B N1. Okay, this is the final report. So next, how do we decide on upfront surgery versus neoadjuvant therapy? More importantly, I think Dr. Divya brought out a very important point, who decides what is going to be done. So Dr. Divya, practice, is it to whomever it goes, or is it your friend who decides next year, or is it the MDT?
The key in deciding your treatment modality lies in a good MDT discussion. So I will definitely take up this patient to an MDT and
so all cases are discussed in an MDT in your center?
majority.
Majority, okay, fine. Dr. Rahul, all cases to be discussed in an MDT, or is it that you just give a call to your surgeon and say, hey, look, this is what it is, what do I do? Should I go ahead, or how would you normally do it?
No, for us, is everybody goes to MDT, even private patient.
Perfect. Dr. Somen?
Yeah, all patients of rectum.
Okay, I think this is a discussion we used to have 3-4 years, that have an MDT discussion. I think by and large that is reducing. I'm not sure in practice, Dr. Vedant, whether all patients in every hospital go through the MDT, but it is what is needed really. You should put it through an MDT to decide. So Dr. Padmaj, again, MDT, we are part of MDT, so we'll be there in the discussion at least. Yes. So that is where it is. So how do you decide on surgery versus any form of neoadjuvant therapy? Dr. Somen, surgery versus any form of neoadjuvant. I'm not going to the details of neoadjuvant at this point, any form of neoadjuvant.
All right, for T1, T2 and node negative, MRI free, for these cases I might take them as upfront surgery. Anything more than T2 or any node positivity with any mesorectal involvement, that goes for neoadjuvant, different forms of therapy.
Selected T2 also, I think you could take them for neoadjuvant also.
Yeah, some of the
selected T2.
Sorry, I didn't get that.
Yeah, some select T2 also can be taken for neoadjuvant. So T1 for sure they will be going for surgery. Most T2 will go for surgery, but some T2 may be taken for neoadjuvant, especially if they are not fit enough, they are low, low anal, so in sphincter is not really.
I think that's the next thing we wanted to discuss. So Dr. Rahul, your take on this, patients T2 and below and node negative for upfront surgery?
So wait and watch is coming big way, and yeah, so at least for the lower 1/3, there is a proponent that you, after opera especially, that you would like to offer them.
So you would like to offer in the low rectal where you are sphincter preservation, organ preservation, any criteria that you would want to use for it? Is it a specifically 75-year-old gentleman, or is it a 45-year-old person who is fit?
So there are definitive criteria by the international consensus for wait and watch. So it should be a non-circumferential growth. It should be non-signet or poorly differentiated.
I think we'll discuss the wait and watch later, but other than that, what is your uptake? For when do you go for upfront surgery, when do you go for neoadjuvant?
So basically, broadly, I agree with what they said. T1, you go ahead with surgery. T2, early T2, upper one, you can go ahead with surgery. Lower 1/3, you would prefer, if it is like near sphincter or something, you cannot preserve the sphincter, you would like to do wait and watch.
Okay. Yeah. Dr. Divya? Same. So early thing, Dr. Vedant, yes.
I have a slightly different view. For upper rectum T3N0, I would operate. Not a problem at all. T2,
so upper rectum, you're saying basically above the peritoneal reflection?
Above the peritoneal rectum. So if you divide in upper third, middle third and lower third, if a good TME is done, T3N0, upfront surgery.
So Dr. Somen, yes, Dr. Rahul.
So T3 N1, I agree there is controversy.
T3 N0.
I said N0.
T3 N0.
N1, I think there is no controversy for anyone. Any node positive, you would go for a neoadjuvant.
So even in T3, if it is very advanced
probably in some time, T3 N1 upper rectum will also come for upfront surgery and avoiding radiation.
If Dr. Padmaj lets it get to you, he will do
I'm not avoiding chemo, I'm just saying avoiding radiation.
So upper rectum or rectosigmoid, if you broadly say it, when it is advanced T3 kind of a thing, bulky T3, then also we sometimes go ahead with radiation first and then doing surgery. And it is center dependent because NCCN is little flexible there as compared to European guidelines. So it varies from the comfort of the whole MDT as such to practice.
I mean, sigmoid, whenever it goes into sigmoid, a significant portion, I think
So
most
it's
of us
very
would just
difficult
go
to
for-
judge those by even various guidelines differ in where is the upper and where is the sigmoid, you know. So,
Okay.
so that's why I said rectosigmoid broadly.
Okay. Dr. Divya.
But even in absence, if there is no sphincter involvement, not all T3s are bad. So now that we know that there's a subclassification of T3, and T3A and 3B are good low risk ones. So if this is when your skill of the surgeon comes into play. If he's confident about having a good clearance and getting a good CRM, and there are no other adverse MRI features, then even surgery could be offered to these.
So there are 3 surgeons on the panel. So skill of the surgeon, these are fighting words from the radiation oncologist. You know, they never say skill of the radiation oncologist when they are sent to you guys. Anyways, just to the lighter vein. Yes, Dr. Rahul.
No, nothing.
Dr. Some, 3A, otherwise fate, would you go for surgery, or is it a dogma that anything beyond 3 has to go for this thing?
So as I said, so for upper rectum it's still debatable. There is no data available whether your doing upfront surgery is going to have a poor prognosis or increased chance of local recurrence, all these. We don't have any data on T3 upper rectum. For anything mid and lower rectum, node positive, there is no question, there is go for neoadjuvant. Your mesorectum is involved or having any high risk features like EM behind, etc., you go for neoadjuvant therapy. But one important point which he has mentioned is the age of the patient and going for a wait and watch policy.
Wait and watch, we'll discuss at the end. We have a slide on that. We'll keep wait
so
and watch for later.
T3, N0, upper rectum, we
We'll
can
wait
go
for it, yes.
we can go for upfront surgery.
Okay, sir.
Yeah, here I would like to put a small caveat for the young guys, that make sure that patient tolerates everything, you know, which is done as a neoadjuvant.
Yeah, fair
Because,
enough.
you know, at a
Tolerance we'll
regional
discuss.
cancer center, we get almost 50% of the patients, they're poor performance status.
That's fine.
So they would not come for the primary at all.
Poor performance status is an area we'll not get into. There's a whole set of different personalized management we'll do. We'll talk of the general patients that we are discussing here.
Especially in T3, I mean, deciding anything, the length of the tumor also will be important. I mean,
So again, right now, as far as my understanding, if it's a T2, if it's long or short, it doesn't matter, you would go for a surgery. Dr. Vedant, is that?
Yeah, but by and large, a very long tumor will not be T2.
Fair enough, fair enough. Point made. Rectosigmoid, I mean, how many of the surgeons agree on the panel with that? Rectosigmoid, you'd go for radiation or go for surgery? I mean,
Surgery.
okay. So Dr. Rahul, your surgeons are much more forgiving probably in your MDT that they're sending for a RT.
I think more than forgiving, I would say that they have reviewed their things and
No,
they
Dr.
have worked on it.
Dr. Rahul categorized it very bulky T3.
Bulky
right?
T3.
Am I right?
So it's advanced T3B
Advanced
disease.
So T3D kind of situation,
Yes.
right?
And that's why MDT plays a role, like what
Fair
you are
enough.
comfortable, what I am comfortable.
Absolutely. Sphincter preservation, how important is it to do over neoadjuvant? How many would actually preserve a sphincter? That's something which, you know, we talk of, at least as a medical oncologist, I don't understand too much of it, but how much do we preserve a sphincter by giving neoadjuvant, Dr. Somen? T2, but involving sphincters, if you give radiation, you can spare the sphincter, is that?
So all the neoadjuvant data which are available, they have not shown any benefit in sphincter preservation rate or type of surgery, etc. But having said that, there is a problem because after neoadjuvant, we don't restage most of the patients.
Okay.
There are some group of patients who actually might have a sphincter preservation after neoadjuvant therapy.
Okay.
So we don't have actual data of that because the restaging is not often done.
Dr. Rahul, I mean,
So I'm not sure, my surgeons will be able to better tell that how many regressed and how many they could do intrasphincteric resections and stuff like that. But we definitely restage all post-neoadjuvant patients routinely and then decide what would be the surgical choice or even wait and watch policy in MDT. So patient after neoadjuvant treatment comes
We'll get
back to
to
the
MRI.
MDT for decisions.
I think that's what routinely we are also. Dr. Vedant, again, this is something we're discussing, ISR
Always,
versus.
always. In fact, if it is felt per rectally, I call them at 4 weeks to see per rectally if it has responded or not, because then I can also decide about timing for surgery.
Perfect. Again, something which all surgeons have said, they trust a rectal examination more than imaging if it is palpable to go ahead with. Perfect. So I think that's where the sphincter preservation is. Not every case will be, what percentage probably? 20, 30,
So
40, 50?
at least 20%.
20% would be able to preserve sphincters. Dr. Rahul, do you agree with that figure? Or?
So traditional wait and watch was 20% successful with 50
So
gray.
you mean
That
to those
would,
20% is where you would probably preserve
it can
it.
be higher with the dose and everything.
Perfect. So far we are having a very nice panel where everybody agrees with everybody else. You know, it's a very uniform panel with a good MDT panel. So this
Careful
is,
to disagree.
huh? You have disagreed. Perfect.
We have carefully disagreed.
So this is what the data has been on the pre-op versus post-op RT. Again, these are trials which are very famous, the MRC trial and the other trials, all of which I think all of the panel knows very well. It's a little busy slide. So I'll just summarize these things. What the pre-op RT does is it gives you improved local control, less acute and late toxicity, and something which as a medical oncologist we keep asking, is there an overall survival benefit? And there's no difference in the overall survival benefit. So are we still convinced that, you know, overall survival benefit not that important, local control more important, so pre-op RT is better than post-op RT? Starting Dr. Divya.
Biology-wise, for rectal cancers, yes, local control is your primary endpoint. It's only when you have advanced tumors, there is a more propensity for the distant failure. So that's where the role of chemo, which will provide you which will
That's a
translate
different
into,
setup. I'm saying just pre-op versus post-op RT. Just RT. Will you give it pre-operatively
no,
or
so
post-operatively?
with concurrent chemo, I would.
With concurrent chemo also, but pre-op versus post-op. Yes, Dr. Sridhar, you were saying something.
It has to be pre-op because the second point that you have mentioned is very important.
Toxicity.
And toxicity.
Dr. Rahul.
At the same time, once again, there is a small caveat. The young surgeon should be very careful in operating such pre-op radiotherapy patients because, you know, sometimes the tissue are stuck there. The small bowel will come and is stuck there. There is a sometimes huge amount of thickening of peritoneum and you might damage the ureter very easily, you know, without knowing.
Again, I'm not very sure with the modern techniques of radiation, really that kind of toxicity is happening nowadays. I mean,
So those happen only with very bulky and
Very
infiltrating
bulky
kind of
tumors.
tumors.
When
Because
preoperatively it
then
was-
there is a lot of fibrosis around, but that's a situation which is very less.
very
common.
less. I think
No, but I agree with Dr. Patel. We have had at least 3-4 situations when we actually did not know what we are cutting through, whether it is fibrosis or tumor. But based on the imaging response, we went ahead and thankfully margins were clear on all occasions. But it was very tough.
Dr. Rahul, your take on this. Any role at all for post-op? I mean, given a choice, of course, patient has come operated to you and you have to give, that's a different situation.
See, we do get patients who are operated outside and they were never considered and they get recurrent, and it's even more difficult because you're treating with gross disease in post-op setting, not even microscopic disease. So how to escalate dose and stuff is difficult. But coming to your slide, real slide,
This
I
one.
don't know what is beneficial. There is like I would say that it is not consistently shown to show a survival benefit, but not that all trials do not show a survival benefit.
Fair enough. Point
So I
taken.
would like to change it a little bit there.
This slide is by a radiation oncologist, not my slide.
Yeah, that is
So this
There's
is
no-
by,
it's
by
not
a
a lie,
radiation
but it's
oncologist.
not a full truth.
Fair enough. Right. So this is the other trials which also have been documented. Again, the same thing. You don't get a survival benefit in all cases, but you do get a trend in some of the trials. That's what you are trying to say. Point taken. Right. So coming now to the whole discussion, which is more interesting now, is short course, long course. Is it even still a discussion, or are we still debating this? Dr. Divya, short course for all or long course for all, or you are comfortable with either of the two?
So both have been compared in trials,
Yes.
short course, and there is no difference in efficacy and the local regional control. However, you will decide on the regime depending upon we would take an account into the MRI high risk features. So if it's a very bulky tumor, T3, C, D, and T4 up with a lot of nodal burden, MRF is mesorectal fascia is positive, there's CRM is breached, and extra pelvic nodes, then we would give a long course RT. So the aim being that we want to significantly downstage these patients, and we can, which will eventually translate into a good local regional control.
Dr. Somin, your thoughts, would you offer the radiation that look, you offer short course versus long course? Are you particular what you think, or you say let the radiation guys decide based on?
My radiation oncologist is sitting there, Dr. Anupam.
Yeah, you
He
can
is the
fight
one
in the
to
evening
decide.
outside in
Anyway,
the tea.
So, just one comment on your previous slide, that is the pre-op RT versus post-op RT.
Yeah.
Maybe in today's era, the role of post-op RT might be in such a situation where you have a upstage T3N0, which you thought T3N0, after you have operated on it, you saw a node positive. So maybe that is the only indication left for a post-op RT.
Fair enough. Again, I think if the whole idea is what I said in the beginning, have an MDT, take a combined decision, and there everyone says it's N0, and then you know, a pathologist finds a note for you, which Dr. Vedant says they should find. So then, you know, that's a different situation. But other than that, I guess I think everyone is going along the same lines, at least as to what should be done. So this is about the short course and short course. Dr. Rahul, your thoughts on this?
So let me put all the perspectives what we have as an MDT. So radiation oncologists love it because, at least in my center, because we can treat 5 times more number of patients. It shows better efficacy of the treatment regimen because more PAT-CRs. Whether they translate in the outcome, trial doesn't show in Rapido, but historically we've been believers of PAT-CRs translating in something more magical. But I think, and the medical oncologists love it because more patients complete their chemotherapy regimens, but surgeons don't like it because in short course, traditionally they would early operate. So the fibrosis is not set in, there's edema, they get better planes, they take it out easily. But when you have short course followed by 4 months of chemotherapy, everything is fibrous, it's much more difficult.
Yeah,
so quality of life of surgeons is bad.
Yeah.
The patient may not be very different from what we have seen in our data. So you know, so that's the whole opinion, but yeah.
So logistical issues are more than the practical issues for you.
Yeah, but I will say in private sector, radiation oncologists also do not favor SCRT because the reimbursement is per fraction basis, some places. So that issue is also there from RadOnc part.
So I think, somebody from the audience wants to ask something. Yeah.
Sir, we are talking of short course and long course of radiotherapy. But when we operate, there is also one margin, there is a distal stump bleeding, which is at times absent, at where we are trying to do a Sphincter preserving surgery. At that time, we are in a soup whether to do it or not to do it.
Most important, most of the time, you know, the healing is little hampered, and we usually do a covering colostomy, otherwise we don't do that.
So this will be the lower 1/3 SCRT patients, I know. That's what my surgeons tell.
And when you use the stapler, you know, that becomes very difficult for us, you know. There is a edematous wall, and there are only 3 types of stapler available, so it gets crushed, you know. So
yeah, that's why I said, so quality
issue.
of life of the surgeon is very bad with SCRT and chemotherapy. That's what.
Again, I mean, is that true as a traditional thinking? Is it changing now, Dr. Vedant? Because, you know, again, we are doing a lot of SCRT in our center, and in fact, we are doing a lot of TNT in our center, and somehow we haven't yet gotten that feedback from our surgeons. So I'm just asking those who have been.
With modern techniques, at least the long course, we have not faced a problem, unless, of course, few cases that I mentioned. Short course, I have not had an experience of operating very late. But Dr. Avnish Saklani is not there, otherwise he would have used the same phrase as Dr.
So
Rahul
that's
said.
what I'm telling you, our MDT
decreases the quality of life of surgeon at the cost of happiness of radiation oncologist and medical.
That is what I tell him, that your quality of life is bad, patient is same.
I think I would request all of you, radiation oncologists, that you should at least take few rounds post-op, so that you realize what are the problems.
No, I've gone with Avnish and seen his OT, don't worry. I know what he suffers with.
Okay. So at all this time, the medical office sit very happily inside. We'll be coming to ourselves, sir.
I want to comment one point between the controversies between the long course and versus short course chemotherapy, radiotherapy. One point is to be mentioned that the short course radiotherapy followed by surgery, the timing gap is
I will come to that,
important.
sir. That is next slide. That is after this. I'm coming to the timing issue also as in this. So again, this is a kind of a summary which says that no difference in sphincter preservation, no difference in the OS or the DFS, really not much difference in the local control between a short course and a long course. Again, the most important thing, I think most corporate hospitals will love to be in the position that you are, that they want to treat 5 times as many patients if they get short course. But anyways, the point being that you can do a short course. We do a lot of short course in our center because we get patients from outside our city. They are happier to finish in 5 days and go back to their city. So that's a logistical issue. As such, there is a trend to improve local control with a long course, especially in distal tumors. So that's something where we are usually preferring to give long course, where there is a cross, seminal vesicle involvement, prostatic involvement, gross visceral disease. Probably that's where long course is preferred, if I understand correctly. Yeah, both the radiation oncologists are vigorously saying yes, so we'll take it as that. Yeah. So now the question is the gap to surgery. So this is where we discuss, the Stockholm study did show that if you do a surgery after 4 to 8 weeks, you have lesser post-op complications. Everyone is saying that traditionally it will be more fibrosis, it will be difficult to operate, but the trial actually showed it opposite way. It showed that you can,
So I was saying in short course when you operate early, you'll have edema, clarity of planes, they will easy. Now it is fibrosis because you're giving 4 months of chemo.
But the trial did not show that. That's what I'm trying to say.
Trial said post-op complications. Did not say intra-op difficulty.
Okay, it's difficult to please surgeons. They're always screaming about something or the other. So this is the trial, the Stockholm trial which showed. So again, are we very now sacrosanct about this period that it has to be operated in 3 to 4 weeks, 10 to weeks, or is the MDT overruling the surgeon's interest and saying no, you have to give TNT, so it doesn't matter when you want to do, this is what we are doing. Is that a more fair summation to say? So yeah, Dr. Vedant is smiling, so I think that's what's happening.
No, I think we agree. We agree with total neoadjuvant. We are yet to adopt it for all our patients, but very selectively and partially probably we are doing, but we'll be doing it.
So Dr. Padmaj, at this point, CTRT we keep talking of, obviously with short course we don't give anything, but long course, capstabine has been a standard. Few trials which said give Folfox, few trials use IFU, few trials use Capox. Where are we right now? Are we just comfortable with capstabine alone, or do we want to still give Capox with RT, during RT? Concurrent.
I think Folfox or Capox, either auxiliary platinum based therapy can be used especially in T4 node positive or bulky disease or T4 disease. If it is T3 disease or N1, you may or may not use auxiliary platinum. You may just do away with using capecitabine or 5FU leucovorin based regimens also. So there is no conclusive superiority of auxiliary platinum based regimen in a smaller tumors early stage.
I think I agree. I mean, we don't use it in our practice at all. Dr. Rahul, your center, anyone is?
No, I agree, because why would you complicate something which is being very well tolerated? You have enough opportunity from opera to give it later on.
Perfect. So now the real question comes of CTRT versus TNT. So TNT for everyone, anything which uses chemotherapy significantly, at least 4 to 6 cycles before surgery, and then radiation also. What is the take on the panel? So
even before actually this TNT came, many of us have been following, you give CTRT, and then there is a gap of at least 6 weeks before you go for surgery.
Right.
So many of us used to give chemotherapy in that period, and then the patient used to go for surgery. So the partial TNT kind of thing was being practiced, and then I think we realized that this works better. So
I agreed with you. We used to do that, but now of course the concept has come of TNT full. So what is the routine practice? Dr. Divya, your center, are you starting TNT or?
Yes, we are doing TNT, and the way we are selecting our patients is again based on your these all adverse tumor factors and MRI features. And so the rationale behind this is you finish all your neoadjuvant chemotherapy, you finish all your neoadjuvant treatment first, which will help in again downstaging, will be well tolerated and will take care of the micrometastasis, and then you go for the
again
surgery.
your practice now has shifted to TNT, at least for these group of patients, node positive, CRM, EMVI positive, MRF involved.
So the patients who are getting with short course, definitely they will go for rapido kind of a TNT.
Okay.
But for long course CTRT, we are still yet to convert them to that opera kind of a TNT.
The which kind of treatment? The
opera protocol kind of a TNT.
Fine.
Yeah.
Dr. Somen, your practice, have you started are you now okay with the TNT? Because it is showing benefit over a normal routine thing. So it is showing your DFS better, 3-year responses are better.
Yes. So we are following the Rapido protocol for the patients who are fulfilling the criteria of the Rapido 1.
Okay, T4 above, not T3.
N2s, EMVI positive, CRM positive, all these we are following the Rapido protocol.
Okay, very good. Dr. Vedant, we were again discussing this. So TNT now is something which should be at least attempted. Again, I think our panel is a bit misrepresentative of the general practice in India. I think because here everyone seems to be doing the TNT, though in clinical practice in most centers they have not yet started doing it. Again, I think to the credit most pure
now,
oncology centers. Yes, Dr.
In addition to we people suggesting TNT, now after that Dostarlimab trial, there are people who are asking for non-operative management. So if now currently I have a patient where he has finished TNT and he is in CR, and now he says, no, I don't want surgery, I'll just observe. So now that component also has come up now.
Absolutely, agreed with you. So that group will come in. So we will talk on that, though it is not a standard of care, but something is. Dr. Somen, you want to?
Points against TNT.
Yes.
So there is a misconception that what is TNT. So everything before surgery If you follow Rapido, everything before surgery. If you follow Prodis 23, something before surgery, and there are some adjuvant therapies also. So there is one controversy. TNT has shown 7% DFS benefit, but there is no OS benefit, although Prodis 23 is showing some OS trend.
Yes, it's only 3-year follow-up and 5 years. It's not yet a long follow-up also.
On sphincter preservation, stoma formation, there is no difference.
No difference.
So these are controversies are still there.
But in practice, what has started doing? Are we going into the TNT type of protocol, or we are still, okay, very good. So these are the same trials that everyone has been talking of, the Rapido trial, like all the panelists have said. Yes, Dr. Divya, you wanted to say. So 5 days SCRT followed by 6 cycles of K-Pox or Folfox, 9 cycles, and then go for a surgery. So roughly 4 months gap. This showed a 7% lower disease-related failure, 7% lower distant metastasis with a doubling of the PAT-CR. Again, Dr. Rahul talked about it. 3-year survival is 89%. So again, any disease which has 3-year survival or 89%, finding an overall survival benefit is not going to be that easy. It's going to take time probably. No unexpected toxicity, no differences in surgery or in post-op complication. Again, a point made by the surgeon that it doesn't really change your surgery. The surgery remains the same. This is the Prodis. Now, Prodis is a difficult protocol. Dr. Padmaj, your thoughts on this as a medical oncologist. Now, when I look at this protocol, give 7 cycles of FOLFIRINOX, follow it up with a long course radiotherapy with capstabine, do a surgery, give 6 more doses of Folfox after that. I mean, I don't know how much I can give this. How do you think? Well,
FOLFIRINOX is difficult to practice in such patients. Folfox, yes, definitely. And a selected group, very fit patients, young patients, maybe FOLFIRINOX.
Yeah, because FOLFIRINOX with even a modification is not easy to give. Very fit patients, and 7 plus 6, you're actually going up beyond adjuvant therapy of a colon. You're giving for more than 6 months. It's not easy to give this Prodis trial, but be as it may, Prodis has also been given. And for them, it is a safe regimen with manageable toxicities. I don't think as most of us would really agree with that point. So this is about the TNT. So again, we have discussed short course and long course and how to decide side effects wise and how soon to start the chemo after the radiotherapy. So Dr. Padmaj, again, I'll get on to you for this. How soon after the short course, they finish the radiation on Friday, when do you start the chemo? Monday morning, or you wait for a gap?
See, not using short course as often. I prefer to use long course. After long course, I usually start chemotherapy about in 10 days to 2 weeks.
2 weeks, so 10 days to 2 weeks. So they're already on capstabine already by then anyways. Yes. So you're giving 2 weeks later. Okay. Dr. Divya, your clinical, your MDT, or what is your practice usually in your center? How soon after?
Try to at least start within 3 to 4 weeks.
Mike, please.
Within 3 to 4 weeks. So
within 3 to 4 weeks. Dr. Rahul?
So long course, by the end of long course, you know what patient is having with the radiation. Any problems, no problems, how much you need to wait. Short course, you have to be careful. So wait for 2 weeks for things to appear. They will not, most of the things will not appear, the toxicity will not be there, and you will slowly land up, and then you'll be confused whether radiation caused it or chemo caused it. So wise to wait for 2 weeks after short course. Long course, you know it, when to take the call.
I agree with that. I mean, I have had this issue because 10 days later they look fine, you start on capstabine, the diarrhea starts. Capstabine especially has been a challenge. I have had patients who had 1 month of diarrhea after this. In fact, Dr. Padmaj knows that case. I was in touch with a lot of people because I didn't know how to manage. Patient developed severe hiccups, severe diarrhea, intractable hiccups after short course when I started the K-pop. So
always wait for 2 weeks.
2 weeks is, I think, a fair enough thing. Again, not a standard, but 2 to 3 weeks is fair enough. So again, we have discussed this, how many cycles, what protocol, and time to surgery. And most importantly, after TNT, the full chemo and radiation, how do we evaluate the patient? So Dr. Soman, you were saying, I think in practice, most of the centers are doing all of these again, a MRI, clinical, and a PET CT, or at least a CT.
Yeah. So we have started doing MRI at least to restage whether we can preserve the sphincter or not. That decision we are taking.
Only for sphincter, would you do it also for a mid-rectum, just to see the response? Okay.
After TNT, I prefer PET CT, especially post radiotherapy. MRI doesn't really give a clear idea about the viability of the disease.
Does it matter?
If you want to observe.
Okay, for observation.
That's the problem now.
Okay, fair enough. Dr. Rahul, Dr. Vivek.
You said MRI does not give the viability of the disease, is it?
So viable disease. So he's saying
there
MRI,
is functional
PET may be
MRI
better for
is
that.
quite good actually. diffusion weighted imaging is
So there
very
is
good.
now standard recommendations
Yes,
how
MRI
to
response
you know
rates.
observe patient by the standard clinical criteria, radiological criteria, and scoping. So you know it is all together. It is not one isolation. First thing, and MRI is pretty good in predicting and telling you with the fibrosis. Diffusion weighted definitely was standard some time ago, but now recently they have raised some post-RT changes. There can be confusion. So but it is overall together, and it is reasonably accurate, and you don't lose patients because you have misdone something or missed something on either of the three.
Also, I want to ask a question. If you are doing a TNT short course followed by chemo, how would you evaluate in between whether the patient is responding or progressing?
So the panel can take that question. I
So,
think,
so the long course, it was very easy. You were doing it at 6 weeks post, chemo RT when you finish. And if you're doing a brachy boost or something like that, then you would evaluate 1 to 2 weeks later when the patient is comfortable with the sphincter reactions and all radiation reaction. And then after that, 12 weeks first assessment, baseline assessment for response evaluation. With short course, we don't know because data is not there much. From my practice, I can tell you, because there's no paper that I can quote and say that how to do it. So in short course, every two weekly. So if you even ask European experts how they're doing it, is every 2 weekly. While on chemo, we do a per rectal examination. And the moment we see the growth curve going in the opposite direction, we send it to surgery. That there's no point in continuing chemo. It is progressing. Please operate. And if it is going further down, then you take a call whether you want to do brachy or not, and still wait for 6 months or 4 months as per opera.
Fair enough, because some centers are doing MRI at 8 weeks.
So again, I
in
personally agree with him.
between.
I think the biggest challenge in the follow-up period of chemo is that the medical oncologists are handling that period.
It is
where
still evolving,
Traditionally,
so
they don't like to do a per rectal examination. Most of us don't do, and at least we don't even remember to do. I think that's worst. If you don't do it yourself, but get someone to do it, that is important. And again, taking take-home lesson is you should do.
Yeah,
Absolutely. Agreed completely on that. And again, this is exactly what European expert had come. He said every 2 cycles, I put my finger and my finger I will trust rather than anything else. MRI as a routine, I think should not be done. It doesn't really help us that much. It's probably
Comprehensive part when you response and taking a call, final
Absolutely.
call.
I completely agree. That's how it should be done. Again, I think the major reason it is not done always is because the medoncs follow it too often. That's the fact of the matter. So this is what it is. Again, the evaluation we have discussed. Okay, somebody has. Is there any way I can take control of this? Right. So these are the ESMO guidelines. Again, by and large, what we have been talking about, they still give an option of only doing SCRT, and that's your wait and watch, Dr. Padmas, in that in the middle. The ESMO has given it as one of the options. We can discuss it later as it is. Now, I was very curious about the NCCN guidelines, because if you look at the NCCN guidelines, anything above T3, they say you have to give chemotherapy somewhere in between. There's no concept of only radiation anymore. It's all TNT in some form of the other. You give short course or long course, doesn't matter, but give your chemo. Give chemo, then you do short course or long course, it doesn't matter. I mean, I think this is where we are possibly evolving to, where you know that all modalities need to be given. How you give it, when you give it is really up to you. Does the panel agree with that? Dr. Rahul, you?
I think most of us by heart agreed, but I think a lot of apprehension is for that 2% mortality. I mean, you must also be seeing, there are patients who will not just handle it, even before. So, that is the major fear, because there is a radically curable patient otherwise, if it just goes for
1% operative mortality maybe, if you operate upfront, I don't know.
No, but still 2% is little.
Yeah, Dr. Somen,
with modern
Dr.
surgery,
Somen and then Dr. Vedant, what's your opinion? You think this is where we are heading to? It seems a bit counterintuitive to me, because T1, T2 you are saying either will only operate, MSI will give IO, will not operate, T1, T2 will give radiation, observe and not operate. Oh, it's T3 now, let's do everything possible on earth for it. It sounds a bit counterintuitive to me. There's no, it's either black or white. That's what it is. But yes, Dr. Vedant. Say it's a very radical approach, once
sir,
you cross T3.
Can I ask one question?
Yes.
Yeah. Sir, is there any way how we can combine long course radiation as well as neoadjuvant? Because
so you want to give chemo first, followed by long course, followed by surgery.
Is there any such kind of protocol? And one thing I just want to understand, that how should we select our patients for long course and short course? Okay, which is that patient who will benefit from long course, and which is that patient who will benefit from short course?
Okay, I think did you come in just now? We have just had a big discussion on that as to which tumors will do better with long course versus short course. So if anyone wants to just summarize that once more. Okay, we have discussed that actually in some detail. I'll talk about it. And regarding your first question, Prodige used chemo first, followed by long course, followed by surgery, followed by chemotherapy. So again, we all discussed that that may not be the best approach because FOLFIRINOX is not that easy to give, right? So this is our patient. What happened? We gave short course RT. This is the planning image. I don't understand anything beyond blue and black and white. So this is the short course reporting post short course followed by 6 cycles of Kpox. This is the report. So the MRI showed a very good response and they also reported the tumor regression grade. So this is the MRI grade which Dr. Rahul was talking about. MRI is to be reported like this. We did get a PET scan as part of our protocol. We are doing for everybody. It's more as a protocol in my institute. I don't advise it for everybody. We are doing it because we just want to see what is happening. And in that there was a near complete response and that's what it was. So surgery post TNT, again the surgeons have been commenting. So this is what we are talking about. How comfortable are we with more than 5 and 6? Role of sphincter preservation and role of ISR, not TATME, it should be ISR at this point. So this is what again everyone has been talking about. So Dr. Somen, are you now reluctantly used to the fact that MDT is going to push a TNT, make sure they get chemo, make sure he comes to you only after 4 to 5 months? I reluctantly a follower of this now.
Yeah, that's what happening for last 5 or 6 months. But for these patients who undergo TNT, surgery, yes, during surgery it's little difficult. But having said that, there are few cases where the planes were very good. This is, I'm telling my personal experience.
Yeah, personal experience is what we are asking.
Yeah. So the planes were very intact. So there are few cases where, as I said, what I am cutting, whether it is tumor or fibrosis, I am not sure. But there are some cases where planes were really beautiful. I don't know whether it's a credit of radiation oncologists or the machine.
I think they would say it's not the credit of surgeon, but the credit of the robo. You know, we go into those arguments. But anyways, that's besides the point. Dr. Vedant, again, your thoughts now reluctant or whatever, you are getting used to it or?
No reluctance. No reluctance. We have been operating after chemo RT at least for a long time now.
Fantastic.
So TNT, yes, it is here to stay. The only thing is which form of TNT. That is what we need to decide, and that is what Dr. Agarwal was also asking.
Absolutely. I think this discussion of short was long, and I think the best discussion is the MDT. Once an MDT gets in, puts up on paper, follows up after 6 months or 1 year, you have 20 patients or each, you know what is happening.
The earlier selection of SCRT versus long course was a very different selection because you are operating immediately after SCRT. So can't take bulky tumors, CRM which is threatened, you can't take it for SCRT. But now, if you see the selection of patients, they were much more advanced in Rapido vis-a-vis Prodige.
Yes.
So, and you are waiting for a longer time. So you are giving much more time for that radiation to act. So
really almost 4.5 months, 6 cycles of Kpox is a very long time.
So selection now doesn't really remain.
And especially with opera, so in which they give neoadjuvant chemo followed by RT versus the vice versa long course. The whole thing of, it's basically radiation and then time for that. And there should be some anti-mitotic agent probably which is enhancing that response in that time, which is working the best. So giving neoadjuvant chemo first before radiotherapy is probably now quite questioned.
I agree with you. For me, more than anything else, the neoadjuvant chemo 6 to 8 doses does cause an effect on the patient's GC. And if I have to compromise somewhere, I think chemo is the one place I will compromise in a rectal cancer. Because of my chemo, if the radiation is impaired or the surgery is delayed, I think that's a challenge as far as I am concerned.
Just
right.
one point I want to make here.
Yeah.
So off late, it's just my personal take on this. And off late, I just come across few 1 or 2 phase 2 studies where they have used FOLFOX, but concurrently with radiotherapy.
So again, we discussed that question of FOLFOX or Kpox with RT. Again, by and large, the
it was
consensus seems
lower
to be
dose of oxaliplatin looks tolerable for younger patients.
What do you gain out of it? Not much. The gain is not much. So end of the day, like everyone is saying, you don't want to compromise your radiation, you don't want to compromise your surgery, so why unnecessarily fiddle with it? That's what Dr. Padma said and I agree with him. So we are not doing it in routine practice. Watchful waiting. So is it being practiced? Dr. Rahul, Dr. Divya, MDT-based approach, are we offering as a standard through an MDT to people? Or are we offering only with those who are elderly, not willing, comorbidities, stuff like that?
So such things start somewhere, and that is where it started, whether it is bladder preservation, rectum preservation, anywhere. It starts with elderly, comorbid, who are not fit for surgery. And slowly they were in lower rectum with good response. Now it is up to middle rectum with opera trial. So slowly things are opening up. And I think it is relevant whenever a technique is not adding to, and it's probably adding to the toxicity or complications, it's better to be avoided. Even for radiation, it is there. From lymphomas, we have walked out, probably, partially.
Mostly.
So yeah, so it is graceful and it is fine, right?
Perfect. So again, Dr. Somen, your thoughts. If somebody comes to you, Dr. Rahul says, look, you're elderly, you're 75, perfect response. And patient says, okay, I'm willing to do a 3-monthly MRI or a 3-monthly imaging. I'm fine with you doing a per rectal examination monthly. So would you be okay with a watchful waiting at this point?
Yeah, for elderly comorbids with patients who are agreeing to follow all these things, I might opt for a wait and watch policy. But the problem with that, not all the times your radiological CR is correlating with actual PET CR. So that's one issue.
Yeah.
The Operatal has shown some benefit in terms of overall survival and etc. There is no difference, but we can wait and watch in some group of patients. Maybe 1 out of 2 patients who have achieved a radiological complete response after TNT.
Your personal experience, how many patients are there like that?
Maybe in last 1 year, 2 or 3 patients.
2 or 3.
Yeah.
Dr. Vedant, your experience?
So I will not offer, but I will accept for an unwilling patient and a comorbid elderly patient, yes.
Fair enough.
So it depends on the denominator. We do a brachy boost after, if we have a very good response after external beam, which increases from the literature is 15 to 20% CCR rate with standard long course CTRT. So it goes to 35% to the doses that we are giving. So if we are able to escalate it to 100 BED, which a lot of groups in the West do, Taewong and Sunny Mint and other people, they have shown it to 85% also. So Opera is also shown it to 45%, although they have not escalated the dose. Only thing they have done is they have waited longer and they have given chemotherapy after long course.
It would be interesting to see surgeons experience intraoperatively for those patients who show regrowth.
No, they do operate. So that is also standard. So 20% will, show regrowth in 2 years. Yeah. So they will get under the knife after that. And brachytherapy, don't think that when we are escalating dose, it is only 12 cc of the volume, 15 cc. We are not doing it to the whole pelvis or whole rectum, not circumferential also. It's just that the tumor, very focused dose.
Only at the bed.
Right. Yeah.
Residual bed.
Yeah, just that tumor.
So this was the Haber-Gamma which actually started the whole thing, and they actually used to do multiple biopsies, which is now proven that you don't need to do. You can just observe radiologically and clinically, and those where surgery was done, by doing that, you could achieve a clinical CR rate of close to 49%. Those who develop local recurrence, most of them could have a salvage surgery as well. So the whole idea is, even if you observe very carefully, I think the most important point is observing carefully and following up.
So the most important part is compliance with this kind of intensive surveillance. The discussion was that if unfit or with comorbidities, you observe them, but these are the people who are less likely to be compliant for follow-up. And then it's very important from medical legal point of view to document the discussion, and that the decision to observe was, surveillance was taken by the patient, and not that we have taken the decision. I think that's very important.
Point taken. I think the MDT can offer that, look, you can observe if you follow up properly. I think that's the
compliance is very important, I agree. I'm not discounting that, but I'm just telling you, if you see any surgical records of at least government setup or even private, the acceptance rate of permanent colostomy is not 100%. Even if they did not have CCR or PAT-CR or whatever CCR you want to believe, they will not come to table.
Yeah, very true.
They will run away.
I have a young patient who has chosen surveillance.
Yeah, I'm saying, so even they don't have CR, but they will not come back. You keep on calling.
Dr. Padmaj is saying it's not necessarily elderly only, even younger might go for it. So Dr. Padmaj, this next is for you only. This is what all of us read everywhere in the WhatsApp in 6 months back. Dostarlimab, from every patient asked every one of the oncologists every question that can we use this drug. So your thoughts on the MSI high population and whether we can do this. How reliable is this immunotherapy for MSI high tumors?
I think I'll take this as a thought-provoking study. I will not offer my patients, Dostarlimab is not available, but if it is available, even then I will not be, this is a phase 2 study, 12 patients, follow-up is
1 year.
Very short, 1 year follow-up median, maximum 24 months. I don't think it is ripe. It is at the best very disrupting, thought-disrupting study. And we can, if something like this happens, I think it is backed by a larger phase 3 study. I would be very much keen to bring it to practice.
Okay. So, Michael, Nevo-EP has shown similar responses. Your PAT-CR rates are pretty high, almost 70-80% in some study. I don't remember the exact study, but it is showing like that. So, you have a patient like this who comes to you with post-RT MSI high and then says, okay, just give me immunotherapy. I will not even do a surgery. I have done my radiation, no surgery, just give me immunotherapy. Would anybody be bold enough to offer it?
There is no data to support that.
No data. I am asking, will anybody bold enough to give it?
It's logical, but then it's difficult to offer that. Even if MBT offers, it's going to be, there is no data. So you are just doing your women fancy. It should be done as a part of a trial.
Agreed with you. Audience, show of hands, patient comes to you with a report which says this is MSI and I says I don't like surgery, I don't like radiation. If you tell me, I will give only with immunotherapy. How many would actually offer that? Show of hands in the audience. Anybody who would offer only immunotherapy to a patient with rectum with MSI high? Okay. So I think Dr. Padmaj, you and I are still backbenchers as far as the MDT in rectum is going to be concerned. We are still not going to reach the day where we can just tell them, look, it's MSI high, out of the way, this is my baby, as they say. So I think that's about the MSI. Again, no real data, but I have a feeling personally this is going to go in the future, and at some point of time we are going to incorporate immuno into rectal early stage also and locally advanced as well. So this is our patient who underwent a LAR, and as you can see, she had a PAT-CR. So the good outcome for the patient, and after PAT-CR, adjuvant therapy we did not give. We are just running out of time, so I am not really going into adjuvant therapy. We had discussed this, that there are trials which has used after surgery, but it's difficult. Most of us would prefer giving it pre-op. Even if there is no PAT-CR, I guess most of us would be comfortable. If we have finished our 6 cycles, then we are not going to give any more chemotherapy. I think that's a kind of a standard for everybody. Right. So this is where we are, and the follow-up after therapy, Dr. Padmaj, your question for this, ctDNA and CTC as a follow-up, would you start advocating for patients?
No proof as yet.
No proof as yet. Very good. Short and quick. So to summarize, imaging is critical to assess the disease status, planning treatment. MRI is the modality of choice as of now. You do a MRI pelvis and CT abdomen and chest, so it is written here fully. Okay, 50 seconds, 30 seconds more probably I just end up. Early T3, N1, upper and mid rectum, upfront surgery may avoid overtreatment. Again, a controversial thing, but it may avoid overtreatment. TNT to be used in suitable patients. Again, CTRT followed by chemo is probably a better sequencing. Again, something which all the panel seems to agree on. CRT versus TNT, you would give any bulky primary threatening CRM a TNT approach. ISR only in selected patients. Lateral pelvic nodes need to be addressed if abnormal. I think these are more or less standard. This was a ASCO guideline which Dr. Vedant brought out to me. This is a post-ASCO update this year where they have given a stepwise assessment of how you should do, including tumor risk assessment, patient factors, then patient preferences, and finally choosing the treatment based on all of this, and a nice flow chart. So this is a very elaborate and quite a short and elaborate thing at the same time. I would encourage you to go through it. What's the future? How do we deliver TNT in its all modalities, combining immunotherapy, better selection for watch and wait? Will AIs replace all of us? That's something which we don't know, and then good predictive biomarkers. So I thank all my panel. I would like to acknowledge the help given by my radiation oncologist who supplied all the slides and all the clinical material as well. So thank you everyone. If there's no other question, thank the panel for a wonderful discussion.